Brain tumors remain amongst the most complex and challenging conditions we confront. There are over 120 histologically distinct tumor types with survival outcomes varying drastically depending on molecular profile and location. As a result, the need for nuanced, multidisciplinary care has never been more evident. While advances in neuroimaging, genomic profiling, and immunotherapy have shifted paradigms, many patients still face limited treatment options and high morbidity. During Brain Tumor Awareness Month, we are reinforcing a shared commitment to early detection, clinical trials, patient-centered research, and ethical complexities of surgical and systemic interventions. From glioblastomas to benign meningiomas, and from pediatric to geriatric cases, we will be spotlighting emerging data, revisiting case studies, and discussing how to translate innovation into outcomes.
Welcome to Baptist Health Doc to Doc, a podcast built for innovation and collaboration by physicians for physicians.
Hello, I am Dr. Manmeet Ahluwalia. I serve as the Chief Scientific Officer, Chief of Medical Oncology, and the Deputy Director at the Baptist Health Miami Cancer Institute. And I could not be more thrilled because today I'm joined by my colleague, Dr. Minesh Mehta, who serves as the Deputy Director and the Chief of Radiation Oncology at Baptist Health Miami Cancer Institute. Welcome, Minesh.
Thank you, Manmeet. And that was an excellent introduction. One of the things I think we should talk about is brain metastases. They constitute by far and away the most common tumor we see in our patients with brain metastases, with anywhere from 200,000 to 300,000 cases annually. So what's new in the world of medical oncology? What are the advances? What are the key things being presented at meetings? What is Baptist Health doing to break the conundrum of brain metastasis?
Thank you for that question, Minesh. And as you know, over the last few decades, radiation oncology has been one of the cornerstones of how we have managed brain metastases. But I'm thrilled to share that at least in the last 2 decades, because of molecular profiling and an advent of targeted therapies and immunotherapies, we've really transformed the medical treatment options for patients with brain metastases. And the great thing is our patients are living longer and with a better quality of life. And I'll take a couple examples to exemplify that. One is, as we all know, lung cancer really has been the poster child of drug development in solid tumors. And so lung cancer also is the most common cause of brain metastases. So we have drugs like osimertinib, which have really transformed the outcomes of patients in EGFR mutant lung cancers. And here in Miami, it's one of the most common types we see because Hispanic patients tend to have 50 to 70% incidence of EGFR-driven lung cancer compared to 10% or so in Caucasian population. So we have been participating on several trials. One of the trials we did here a few years back was combining osimertinib with radiosurgery. And we showed that the combination was safe, and we are going through the data to present on the efficacy in the upcoming meetings. More recently, we've been thrilled about the real advent of antibody drug conjugates, which are these Trojan horses or smart bombs, as I call them, which are really transforming outcomes of patients, particularly in breast cancer. And a drug that I would love to highlight is this drug called Enhertu, which is an antibody drug conjugate against the HER2 protein, which is expressed on these 20 to 25% patients with breast cancer. And this drug is so great that it is beating the first generation drug by like 4 times almost. And the response rates, we thought that, these large molecules may not be able to get to the brain. But it was so exhilarating to see that the response rates between 40 to 70% is being seen in various trials, depending on when these molecules are introduced. That are they introduced before or with radiation, or they are introduced after radiation. Now, in terms of Miami Cancer Institute, we obviously have been a big adopter of innovation and leading that not only at Miami Cancer Institute, but nationally and globally. So I would like to outline a trial that we participated in and led actually, is a trial using a blood-brain barrier disruption system, where we are using ultrasound to disrupt blood-brain barrier. So as we know, in brain tumors, one of the challenges that we've had compared to the rest of the body is this lining around the brain called the blood-brain barrier, which makes it difficult for the drugs to get to the brain. And so we are using this technology where we are combining this with drugs like Keytruda or pembrolizumab, which is an immunotherapy which has transformed the outcomes of patients in cancer. and really is the foundation, and using that with chemotherapy. And I'm very excited to share that we will be presenting this research at an upcoming meeting in ASCO, where we led this study globally, and we've partnered with some of the marquee institutions, both in the United States and Canada. So I think as a medical oncologist, I could not be more excited about what we are able to do for our patients with brain metastases. But as I said before, this has been a disease where radiation oncologists have really been one of the major vanguards of how we have treated patients. So do you want to share with our colleagues what are some of the exciting things going on in radiation oncology when it pertains to these brain metastases trials?
Indeed, yes, Manmeet. I would love to share some of the exciting developments. So as you know, stereotactic radiosurgery has become the dominant form of radiation in managing patients with brain metastases. Yet there is a lot we can do to improve on our outcomes. One of the areas that we're studying very actively is how to best combine stereotactic radiosurgery in patients that undergo resection of brain metastases. We're about to complete a trial and then launch a next generation trial for this. And we think that we're going to significantly improve the outcomes of this combinatorial approach of therapy. Another area that we're looking at is to make radiosurgery even safer. For example, traditionally, radiosurgery has been used as just one treatment. But we know that for the larger metastasis, if we break it down into maybe 3 treatments, for example, it might be much, much, much safer. So one of our colleagues, Dr. Rupesh Kotecha, is leading a national trial through NRG Oncology, where this is the precise question that he's asking. And it's a matter of great joy and pride for us at Baptist Health that we have one of our own, Dr. Kotecha, leading this trial. As we continue to improve the outcomes of patients with brain metastases, there is the extreme end of metastatic disease in the brain called leptomeningeal carcinomatosis. This remains a huge challenge because the outcomes of these patients remain poor. And herein, we are participating in a national trial that is looking at proton craniospinal radiation. We are one of the few institutions that has access to proton therapy, and we can deliver this therapy for patients. A phase 2 trial showed significant benefit. Now we are part of a phase 3 national trial for this particular question. And since we talked about national meetings, last year we had the pleasure of presenting our results from something called tumor treating fields, or TT fields therapy, that actually takes care of the rest of the brain. When we treat tumors with stereotactic radiosurgery, we still see failures elsewhere in the brain, and this therapy in combination with stereotactic radiosurgery might improve time to overall progression. So we led that national trial. You and I both had the pleasure of being on that trial. And so it's actually great that we at Baptist could participate and lead trials of this nature. But that's just the universe of brain metastasis. We have this lethal disease, glioblastoma, that we confront on a daily basis. And many of our patients come in with this diagnosis, and this is a life-shattering diagnosis. This is a diagnosis where we sorely need advances. Could you share with us what's going on in terms of some of the novel advances in managing glioblastoma?
Sure. So as you outlined, this is definitely a tumor type where we can all use a lot of help, because this is one of the ones where, we still, despite our best efforts, have not been as successful as we have been in the era of brain metastases. So in glioblastoma, obviously, we just participated in a trial where we were using a vaccine which was targeting Cervivin. It's a Cervax. It's almost a peptide-based vaccine which targets Cervivin. And we had produced some of the early data. We had a phase 2 trial that I led when I was at Cleveland Clinic. And now I'm happy to state that, we actually had a randomized trial which enrolled ahead of time, which just demonstrated the excitement in the investigators around the country. And this trial was open here at Miami Cancer Institute. And one of our colleagues, Dr. Yaz Odia, was our PI on that study. And we are awaiting the results of that study, which will probably be available another year from now. There is also a lot of excitement about CAR T-cell therapies. There have been a couple of smaller trials showing preliminary data that could be an exciting avenue. You and I have been trying to work. Can we bring that kind of technology in collaboration with Florida International University, utilizing some of the strengths that we have in bench science here, and work collaboratively with neurosurgeons like Michael McDermott, who's our partner in Miami Neurosciences Institute. I would like to outline 2 other studies that are actually being led, multi-center trials that we are leading out of Miami Cancer Institute, where I'm very excited about. One is a study where we are trying to understand the heterogeneity of glioblastoma. As we know, glioblastoma is one of the most heterogeneous tumors, and that's why it has been so difficult to treat. So one of the trials that Dr. McDermott is leading as a co-PI. We are trying to understand what are the genomic drivers, but we are also trying to understand the transcriptomes and also the epigenomes. As you know, that is a big area of interest these days. And we have, now a very renowned neuropathologist working with us as well on that protocol. And this is a trial we plan to do in collaboration with Cleveland Clinic. Then another study that we are very excited about is this study with a JAK-STAT inhibitor called ruxolitinib, where we are combining that with radiation and chemotherapy in temozolomide. And we will randomize patients to receive ruxolitinib in addition to radiation and chemotherapy. And this will be a fairly large trial of over 180 patients, and Miami Cancer Institute will lead it. Dr. Ardia is, a site PI again and a co-PI nationally, and we are looking forward to partnership with you and Rupesh Katoch on it. So I could not be more excited. Obviously, we have a long way to go ahead, but there are several fronts where we are trying to move the needle. And obviously, as you know, radiation again has been a backbone of treating glioblastoma. So what are some of the things that you are excited about, especially given we are one of the marquee centers using proton therapy?
Since you mentioned proton therapy, one of the trials we're most excited about is a trial called BN001. This is a trial that we have now completed accrual to, and this is a trial that's testing the value of proton therapy in patients with glioblastoma. We were the lead site for this trial. We led this trial nationally. The trial has completed accrual. At one of these upcoming meetings, the results will be presented. I still don't know the results. They are under statistical review at this point in time. And as soon as they're available, we are somewhat excited that perhaps this might be a positive trend and we might have something for our patients. But talking about proton therapy for gliomas, another area where the benefit of proton therapy shows up so well is in preservation of normal structures and normal tissues. And in patients with gliomas that have longevity on their side, patients with lower grade gliomas, we've also completed a randomized trial where we have tested this question, whether we can save cognition and memory. And again, we are awaiting the results of this trial. We are quite interested about some of the innovations in advanced imaging. Advanced imaging, especially using PET scan imaging and some of the MRI techniques, can allow us to identify areas of glioblastoma that might be beyond what we can see with conventional imaging. And perhaps targeting these areas with radiation might make a difference in changing the outcome of these patients. We believe this to be potentially true because there are recent data from the surgical literature that if we resect beyond what we can see, a group called Reno Resect led this concept, and they categorically showed improved survival. We believe that radiation can learn a lesson from this Reno Resect information and push the frontiers of radiotherapy further. So these are exciting times for us, for our patients who have a very, very serious and critical diagnosis. But we've talked about many serious diagnoses, and maybe we should talk about some of the tumors where we have the potential to actually expect and deliver a cure, a tumor such as meningioma. What are the key advances in meningioma that you would speak about?
Well, again, as you know, meningioma is the most common benign tumor we see in the clinic. And what I would say is, again, no surprise, radiation has been, typically being used once we resect this tumor, obviously. So the dogma has been surgery, or radiation as much as you can do. And typically that's when these patients would come and see us in medical oncology. What I could not be more thrilled to share with you that there is a lot of the exciting trial actually is coming out of, again, Miami Cancer Institute, where Drs. Yaz Odia and Rupesh Katocha have actually took a very nice case that they had. Dr. Katocha was treating a patient where he was treating this patient with cabozantinib, which is a tyrosine kinase inhibitor or a targeted drug that targets multiple pathways, including VEGF, which we know is important in meningiomas. And what he found was that that patient's tumor, which was a meningioma in that case as well, shrank. And so that observation from one patient, an anecdotal case, actually then led to a study where he and Dr. Odia now have treated several patients with this drug called cabozantinib, which is used typically for kidney cancer patients. And in the first few patients that we have treated, we have seen very nice or remarkable shrinkages of tumor. And there is actually a new generation inhibitor that is coming down the pike, and Drs. Katocha and Adi are again working, I know, with NRG now to see if they can, do a concept at a larger national level. But I know you've been working for over 3 decades now in that field as well. And there are some exciting avenues, both on the genomic front, but also in terms of radiation. So what are some of the advances you have seen?
So one of the key things that I'm excited about is a whole new line of therapy called theranostics. And this is a line of therapy where we can take an agent combine it with a diagnostic marker, which can identify and delineate a tumor, and then supplement or supplant the diagnostic marker with a therapeutic marker, an isotope, that can go to the same location and treat the tumor. So this is effectively liquid radiotherapy. We have a clinical trial about to launch using an agent called lutetium, and this trial has shown some early dramatic responses. The trial will be restricted to patients with recurrent and refractory meningiomas. We're very excited to bring this to our patients and see if we can make a difference. But you mentioned the role of radiotherapy in newly diagnosed but high-risk meningiomas, where it's generally accepted that radiotherapy has value. But what is little known is that about 20% of patients with the lower risk category of meningiomas, which is the dominant subtype of meningioma, these 20% will relapse. And up until now, we have not known how to pre-identify these patients and therefore try and do something for them. We now have a molecular signature that we have worked on with our colleagues from University of California in San Francisco. And using this molecular signature, we can now pre-identify patients that are at the highest risk of relapse. And we're about to start a trial where such patients would also get postoperative radiotherapy. So these are indeed exciting times. I'm very, very excited to be working with colleagues like you, with Dr. McDermott, with Dr. Odia, with Dr. Kotecha, and several others in our team, including our imaging group and pathology, who really make it possible for us as a comprehensive multidisciplinary team to target the more than 120 types of brain tumors that you talked about. So let me turn it back to you for closing comments.
Well, thank you so much, Binesh, for sharing some of the exciting developments in the field, but I would be remiss if I do not give a shout out to you. You have been a leader of radiation oncology for brain tumors, not only in the last decade you've been at Miami Cancer Institute, but in the whole field globally for the last 3 decades or so. And we have learned so much, working with you, and it's just been a true joy. And we always say in oncology, it takes a village to take care of patients with cancer. And certainly it's true for a complex cancer like brain tumors. And I could not be more thrilled working besides with you, Dr. Michael McDermott, who leads our Miami Neurosciences Institute, but also leaders like Dr. Yasmin Odia, Dr. Rupesh Katocha, Matt Hall, several of our colleagues who are driving the field, not only here locally, but nationally and internationally. And one of the things that we take a lot of pride in is bringing those cutting-edge treatments for our patients here in South Florida and beyond. And as we close, we are reminded that brain tumors are not just a clinical challenge. They are a human one. The science is complex, but so are the lives we touch. Every scan, biopsy, and protocol represents someone's hope. Brain Tumor Awareness Month is not just about highlighting what we know. It's about recognizing how far we still have to go. From refining surgery and radiological precision to unlocking new targets in glioma biology, our responsibility as clinicians is to keep pushing the boundaries of what's possible. And I'm so delighted we are doing this at Miami Cancer Institute every day. Thank you for joining us. Stay engaged, stay informed, and most importantly, stay committed. Your expertise doesn't just treat disease, it shapes futures. Thank you.
To find out more about the topics covered on Baptist Health Doc to Doc, please visit physicianresources.baptisthealth.net.